All right, we are going to continue. Next, I would like to ask Dr. Eshov to come on to camera. And Dr. Eshov is joining us from Skagit, and we'll be changing the theme a little bit. And we are going to shift to the GI track for our next two cases. And Dr. Eshov, if you could share your slides and then come on to camera. And just a quick reminder to all of our audience, thank you so much for putting your questions in the chat, or rather in the Q&A, sorry, in the Q&A. All right, we can see your slides. If you want to go ahead and start.
All right. Hello, everybody. Good morning. My name is Dr. Eshov. I'm with the I'm in PGY2 in Internal Medicine Residency Program at Skagit Regional Health. And this is my case report on bisacodyl suppository-induced ischemic colitis. Bisacodyl is a laxative that has a 3.5-hour onset of action with both secretory and stimulatory mechanism. In rare cases, increases the risk of ischemic colitis. Here we introduce a 51-year-old female with a past medical history of umbilical hernia, diabetes type 2, coronary artery disease, who was admitted for management of parainfluenza. On the fourth day of the hospitalization, patient reported abdominal pain and noted that her last bowel movement had occurred 5 days earlier. She was started on Daylesena, polyethylene glycol, and bisacodyl suppository. The following day, despite having small bowel movement, she continued to experience abdominal pain, prompting a CT scan of the abdomen. After returning from imaging, physician was called into the room for concern of worsening abdominal pain. On quick history of the patient, she did not have any abdominal or pelvic surgeries. Home medications included ibuprofen, clopidogrel, atorvastatin, docusade, levothyroxine, and amitriptyline. Hospital medications included fibrates, opioids, polyethylene glycol, senna, statin, and bisacodyl suppository. She had a minimal smoking history. Patient was seen right after the imaging, and her physical exam was significant for abdomen that had generalized tenderness to palpation, but was non-distended with normal active bowel sounds. There was also an umbilical hernia that was tender to palpation, but was non-reducible and non-erythematous. CT abdomen at that time revealed prominent stool in the colon. These were the labs, and they were unremarkable at that time. Here's a quick timeline on day 4. Patient received her first dose of bisacodyl suppository, and on day 5, she was taken to CT imaging due to continued abdominal pain. After returning from the CT, patient continued complaining of abdominal pain, so physician was notified and secondary dose of bisacodyl was given. 5 hours after the first secondary bisacodyl administration, patient developed hematochezia and was noted to be passing copious amount of blood clots while soaking through her pads. H&A check at that time revealed hemoglobin of 11.9. She was sent to a CTA abdomen, but had to return quickly due to syncope. At that time, her blood pressure dropped to 58/39. Due to hemodynamic instability, we started her on IV fluids and administered 1 unit of red blood cells. Once we stabilized the patient, she was taken back for CTA abdomen, and her labs were redrawn, and they revealed the hemoglobin dropped from 11.9 to 8.4. And CTA abdomen impression showed that there was thickened rectum concerning for proctitis without arterial extravasation, and there was additional increased fecal loading. Of note, both mesenteric artery and the portal vein were both patent. 14 hours after second dose of bisacodyl, patient was taken for a sigmoidoscopy. This is the sigmoidoscopy results. Sigmoidoscopy revealed rectal ulcers with blood clots consistent with ischemic colitis, as you have seen in the arrows. GI PCR at that time was negative for any infection causes of her event. Later on, sigmoid ulcer biopsy revealed injury that was ischemic in nature. So ischemic colitis is a vaso-occlusive or non-vaso-occlusive disease. Risk factors include female gender, age over 65, constipation, medications such as opioids and laxative, and cardiovascular disease. Symptoms include acute abdominal pain, hematochezia, and diarrhea. Definitive diagnosis requires a colonoscopy, and treatment is usually conservative management. So first, we looked into medications that our patient might have been taking that may have increased their predisposition for ischemic colitis. And in this analysis of the federally adverse event report showed that 30 medications that had increased risk of ischemic colitis. Of note, two-thirds of these medications listed did not have ischemic colitis risk in their package inserts. As you can see, our patients' medications included fenofibrates, opioids, Miralax, Senna, statins, all of whom were listed on the 30 medication list. Then we looked at constipation as the potential risk for ischemic colitis and found that constipation had threefold relative risk of ischemic colitis in patients with constipation as opposed to those without. After some further research, we found an analysis of ischemic colitis cases for patients who were taking bowel prep, showing that oral bisacodyl had the strongest disproportionality signal for ischemic colitis, reporting it at 7.9%. Of note, our patient had bisacodyl suppository as opposed to oral. Shamatsutu et al. Proposed mechanism where bisacodyl causes stimulation of the colonic muscle, which increases the oxygen demand. Musculature contracture leads to compression of the vasculature in the colonic wall. This, in addition to the secretion of the fluid into the lumen from the vasculature, decreases the blood supply from the vasculature, leading to watershed areas becoming high risk for ischemia. This is 2 days after conservative management. Our patient was placed on conservative management, bowel rest, antibiotics, removal of the offending agent, and on hospital day 8, she was taken back for a colonoscopy, revealing a complete recovery. And as you can see, there's no more ulcers or hemorrhages. Our case had a patient with ischemic colitis that was caused by bisacodyl suppository. Along with bisacodyl, our patient did have risk factors for ischemic colitis, such as constipation and certain medications. We believe that bisacodyl was the cause of her IC at that time due to the abrupt change in her status and the timing of her hematochezia being within 5 hours. As you remember, bisacodyl's onset of action is 3.5 hours, and then another additional 20 to 30 minutes for the secretory mechanism. Our patient had a complete recovery with conservative management. In conclusion, bisacodyl suppository-induced ischemic colitis is a very uncommon complication that should be monitored. Conservative management with the removal of the bisacodyl is sufficient in treatment of ischemic colitis, and all patients should get a review of medications closely prior to administration of any bisacodyl or other agents that may increase the risk of ischemic colitis. Thank you so much. I would like to thank Dr. Davidson, Dr. Bing, and all of my internal medicine administration for helping me in this presentation. If you have any questions, I'll take them now.
Great. Thank you so much. Very interesting case. Really appreciate your reviewing the argument or the case for why the bisacodyl contributed. We have some questions. So first question for you. Do you think like the severity of the constipation with that significant fecal load that you showed us on CT was a factor? And then the second part of the question, in general, should we avoid stimulatory laxatives, in particular bisacodyl, in patients who are very constipated?
So it's a very good question. Originally, I think that the constipation may have been a predisposing risk, but not necessarily what have caused the ischemic colitis. I think that the worse the constipation, the higher the risk of getting ischemic colitis, especially with the research paper showing 3-time-fold relative risk. For the second part of the question, me and my team are now actually a little bit more apprehensive about giving bisacodyl suppositories because of that. Does bisacodyl suppository cause ischemic colitis for everybody? Not necessarily. I think that you need to weigh the risks and benefits when it comes to administering this medication. I would prefer avoiding the medication altogether at this time for patients with constipation, but that's just personally my own recommendations. I don't think there has been any research done to show what is the actual relative risk of getting ischemic colitis with suppository bisacodyl, which is why this research, well, a case report was more important for us.
Hmm. Well, thank you. And I think it makes many of us wonder then, kind of preferring an osmotic laxative to a stimulatory laxative. One of the other questions is you showed how many of those other medications have an association with ischemic colitis. Did you stop or recommend reduction in any of the other medications? And it looks like some of those medications are, of course, constipation inducing in and of themselves.
That's right. So yeah, at that point, when we found out that she had ischemic colitis, we did discontinue her atorvastatin, which we thought was low risk anyways. We did discontinue the high dose opioids, but unfortunately, she had to be on some sort of opioids because she did have other comorbidities like chronic back pain. We tried to minimize the opioid administration. Other medications, such as fenofibrate, was discontinued as well at that time. Yes.
Great. And we still have a couple questions, one of which is in the chat, if you wouldn't mind afterward taking a look at. And I think Dr. Vanderbilt is making a really astute point that we want to be cautious in a patient with abdominal pain about the use of laxatives in general, particularly while we're still trying to sort out the cause. But thank you so much. That was a fantastic case.